Module 5, Lecture 4, Disease Affecting the Vessels. We're going to explain the etiology, history, physical findings, and management of aortic aneurysm, acute arterial occlusion, acute deep vein thrombosis, and other vascular disorders. Aortic aneurysm. An aneurysm is a dilation or outpouching of a blood vessel or the wall of a chamber of the heart. If the vessel wall tears, then its layers can separate in a process called dissection. May begin with a tear in the inner lining of the aorta, which is the intima, near the weakened portion of the vessel. Blood flows through the tear and between the layers of the vessel wall, exposing the middle layer to blood under high pressure. The blood fills the space between the layers of the vessel, causing them to separate or dissect. A false channel is formed between the intimal and medial layers. If dissection goes back to the aortic valve, it may not be able to close. Blood will regurgitate into the left ventricle during systole, and you may have compromised coronary blood flow. If the dissection involves the takeoff point of the innominate left common carotid artery or left subclavian artery, blood flow through the affected arteries will be diminished. Most begin in the ascending aorta within 2 inches of the aortic valve or in the descending thoracic aorta at the site of the ligamentum arteriosum. Risk factors include tobacco smoking, high blood cholesterol, hypertension, and CHD. Aneurysms of the ascending thoracic aorta are usually caused by cystic medial degeneration, a connective tissue disease in which normal elastic tissue is replaced with cyst-like connective tissue. Signs and symptoms depend on the location. The pressure of a large amount of blood on the surrounding organs may produce symptoms. The patient's description of the pain provides clues to the location of the dissection. Almost all patients report the abrupt onset of constant, unbearable pain. The ascending aorta dissection is usually associated with pain that is either substernal or located in the neck, throat, jaw, or face. Descending aortic dissection usually produces flank pain, pain between the shoulder blades, pain in the back, abdomen, or lower extremities. It may be difficult to distinguish the chest pain of a dissecting aneurysm from that of an AMI, but a number of distinctive features may help differentiate it. These features include feeling of impending doom, pain, weakness, numbness in the extremities, signs of myocardial ischemia, heart failure, altered mental status, signs of stroke, paraplegia, cardiac arrest, sudden death, or syncope. Ascending aortic dissections occur in younger patients previously in good health. One or more of the vessels of the aortic arch is compromised. Pressure differences greater than 20 millimeters of mercury between the arms may indicate the presence of an aortic aneurysm. Suspect dissection if this finding is accompanied by acute neurologic changes. They also may show signs and symptoms of stroke. ECG changes characteristic of myocardial ischemia may occur when the dissection extends proximal to the coronary artery ostia. Descending aortic dissections are common in older patients, especially in those with a history of hypertension. Pain is less severe. The distal pulses may be hard to feel. Rupture of a thoracic aneurysm may occur. Signs of hemothorax may be present if the dissection ruptures into the pleural cavity. Signs of cardiac tamponade may be present if the dissection ruptures into the pericardial cavity. Rupture of an abdominal aortic aneurysm may occur. Will ordinarily be associated with sudden back pain, accompanied by abdominal pain and tenderness. The patient might be hypotensive and have a pulsating abdominal mass between the xiphoid process and an umbilicus may be present. Sensitive to palpation and may be quite tender. Abdominal distension usually occurs, and massive GI hemorrhage may be present. Your management. The goal of pre-hospital management is to provide adequate pain relief and rapid transport. Acute arterial occlusion and acute limb ischemia. An occlusion would be a sudden disruption of arterial blood flow that occurs because of a thrombus, an embolus, a tumor, or direct trauma. A thrombus, when a blockage affects an extremity, blood flow to the muscle is limited. During exercise, muscle contraction may stop blood flow. The process occurs gradually, allowing collateral circulation to develop. If extensive collateral circulation develops, the patient may notice no change and only mild increase in symptoms. An embolus is the most common Conditions that favor origination in the heart include atrial fibrillation, clot formation in the left ventricle after AMI, a rheumatic or prosthetic heart valve, and left ventricular aneurysm. Arterial emboli can travel to a variety of sites in the body, but most lodge in the femoral artery. Most emboli occur in patients with significant underlying heart disease. Direct trauma can be caused by extremity injury, diagnostic procedures such as cardiac catheterization, dissecting aneurysms, vasospasms, or blockage of a vascular graft. Acute limb ischemia results when an arterial occlusion suddenly reduces blood flow to an arm or leg. 10% of patients experience intermittent claudication. 40% of patients present with atypical symptoms, such as leg tiredness or fatigue, and the remaining 50% of patients are typically asymptomatic. Gather a good history. If symptoms occur suddenly, an embolus is the probable cause. If symptoms occur gradually, a thrombus is the probable cause. And find out if the patient has ever had a similar episode. Remember the 5 P's of acute arterial occlusion: pain, pulselessness, pallor, paresthesia, or paralysis. Finding out whether the patient has risk factors for developing a blood clot could be very important. These include recent extremity injury, IV drug use, heart surgery or AMI, clotting disorders, pulmonary embolisms, atrial fibrillation, contraceptive use, hormone replacement therapy, or rheumatic heart disease. Also, look at the skin color of the affected limb. The skin of the affected limb usually appears pale or mottled, distal to or over the affected area. The foot will turn pale when it is raised and very red after 1 minute of placing it at a level lower than the heart. The skin of the affected limb may feel cool and may be either moist or dry. Feel the brachial, radial, femoral, posterior tibial, and dorsalis pedis arteries in pairs. Notice any differences between the two. The peripheral pulses may be absent or diminished in the affected limb. Assessing movement and sensation in all extremities. Check the heart rate and rhythm. Check the patient's blood pressure in both arms. Listen for a bruit over the affected vessel or vessels, and watch for signs of chronic limb ischemia, which may be present if the patient has had symptoms of peripheral arterial disease for some time. If limb ischemia affects the lower extremity, sit the patient up with the feet lower than the chest. Establish an IV line, apply a cardiac monitor, and apply the pulse oximeter and oxygen administration. Give medications as instructed by medical direction. Keep the ambulance warm to avoid vasoconstriction of the skin, and transport rapidly. Monitor the 5 P's that we just mentioned. Acute DVT. Thrombophlebitis is the development of a blood clot in an inflamed or damaged vein. Superficial thrombophlebitis occurs when a clot develops in a vein near the surface of the skin. A DVT is present if a clot develops in the deep veins of the extremities, associated with an increased risk of pulmonary embolism. 3 important factors: venous stasis, damage to the inner lining of a vessel, and blood clotting disorders. The patient may seek care because of swelling, pain, or tenderness in a limb. Discover any risk factors associated with DVT. Carefully assess the patient's upper and lower extremities. Compare the extremities in pairs. Look for signs of inflammation of the skin over the affected vein. Look for pain and tenderness of the calf muscle or dorsiflexion of the foot, which is also known as Homan's sign. Be careful not to rub or massage the affected limb, because this could dislodge a clot. The differential diagnosis for DVT includes arthritis, cellulitis, muscle or soft tissue injury, or superficial thrombophlebitis. Supportive care is mainly what you're going to do in the pre-hospital setting. In transport without lights or sirens, if the patient refuses care repeatedly, urge him or her to accept your assistance, including transport. Consider contacting medical direction for advice and document the patient's refusal.